Principles of analytic use. You can either unmute and speak or type in your chat box. What are the principles involved in analgesic use? So the principles involved in analgesic use are by the mouth, by the clock, yes, by the ladder. Thank you. Thank you for those responses and also individualized treatment. So what do you mean by the mouth? As much as possible, use oral preparations. If the patient can take medications orally, always go for oral preparations. Yes. And what do you mean by the mouth? So by the mouth means that by the clock means that the medications has to be given as the correct frequency as the dose, as per the dose. Yes, timely and in correct frequency, the medication has to be given. So that is by the clock. And by the ladder. What does by the ladder mean? Can someone tell me what is by the ladder? Yes, yes. Thank you. Thank you for those responses. By the ladder, as per the WHO analgesic ladder. So you have already dealt with the WHO analgesic ladder. You have done the step 1 of the WHO analgesic ladder. Can someone elaborate on what is the WHO analgesic ladder for management of cancer pain? You have already dealt with step 1, I think. Yes, step 1 for mild pain. Yeah, what is WHO analgesic ladder for cancer pain management? Yes, it's a stepwise approach. Depending upon the severity of the pain, we prescribe analgesics for cancer pain management. So that is WHO analgesic ladder. So today we'll be dealing with the step 2 analysis, the step 2 opioids and step 3 opioids. So what all will be discussed in this session? It includes the commonly used opioids, the mechanism of action of opioids, practical aspects of opioid use, the adverse effects of opioids, and a comparison between the prices of different opioids. So you have already dealt with this, the WHO analgesic ladder for cancer pain management. So if it is a mild pain, usually step 1 of WHO analgesic ladder is being prescribed, which includes non-opioids plus or minus adjuvants. And if it is moderate pain, we move on to step 2 of the analgesic ladder. That is opioids for mild to moderate pain plus or minus step 1. And if it is more severe pain, we move on to step 3. And step 3 includes opioids for moderate to severe pain plus or minus step 1. So what is step 1? So non-opioids plus or minus adjuvants. What are non-opioids? Yes, NSAIDs. So what are step 2 opioids? Can someone tell me what are step 2 opioids? Yes, step 1 is paracetamol, NSAIDs. Yes, step 2 is tramadol, codeine, tapentadol. Yes, opioids for mild to moderate pain comes under step 2. And step 3 opioids include opioids like morphine, fentanyl, methadone. They are step 3 opioids for moderate to severe pain. Non-opioids includes paracetamol, ibuprofen, NSAIDs like ibuprofen, mefenamic acid, naproxen, diclofenac, indomethacin, etoricoxib. We have adjuvants like tricyclic antidepressants, SNRIs, anticonvulsants, anticholinergics, corticosteroids, NMDA antagonists, muscle relaxants, and the opioids. The step 2 opioids includes codeine, dextropropoxyphene, tramadol, tapentadol, and step 3 opioids, morphine, fentanyl, methadone. So today we'll be dealing with step 3 opioids. So we'll be moving forward through a patient scenario. So I hope this will be an interactive session so that the learning becomes easier. So we have a 56-year-old man with the carcinoma of larynx. So who has presented with severe pain, 10 on 10 pain, which is a sharp, not radiating kind of pain since the last 2 weeks. And the patient is unable to sleep due to the pain. Suppose such a patient comes to you, how will you manage this? Can someone unmute and titrate the dose of morphine? Yes, Dr. Shruti, buprenorphine is also a step 3 opioid. Yeah, start morphine with, okay, so everybody is suggesting in terms of morphine. But in this patient, the patient is having 10 on 10 pain. So depending upon the severity of the pain, there is no doubt that the patient needs step 3 analgesic ladder, where opioids for moderate to severe pain are prescribed, which includes morphine, fentanyl, and methadone, buprenorphine, etc. So these are available in India. The opioid step 3 opioids available in India. So since the pain is 10 on 10 and we need immediate relief, usually we go for a procedure known as IV morphine titration, intravenous morphine titration. Anybody knows what is the immediate side effect of morphine? Sorry, doctor? Dr. Subha?
Constipation.
Constipation. Immediate side effect. Yes, it is nausea. It is nausea is the immediate side effect. Yes, nausea and vomiting is the immediate side effect of morphine. So when a patient present to you with 10 on 10 pain, the most ideal way to go about would be the intravenous morphine titration if you have a morphine ampule available with you. So morphine, one ampule of morphine contains 15 milligram of morphine. So this one ampule is diluted with 9 ml of diluents and a 10 ml in such a way that the 10 ml contains 15 milligram of morphine. So that 1 ml of the diluent contains 1.5 milligram of morphine. And this 1 ml is given every 10 minutes. And this is repeated every 10 minutes until the patient has adequate pain relief or the patient becomes drowsy. Whichever happens first would be the endpoint of titration. So, as I mentioned, we'll go by injection morphine 1.5 milligram at 10 minutes interval. So 1 ml of the diluent will contain 1.5 milligram of morphine. So in every 10 minutes interval, this morphine would be given and the patient pain score as well as the respiratory rate and other vitals would be verified and recorded. And the endpoint of the titration would be either satisfactory pain relief, the pain score comes down or the patient becomes drowsy, whichever happens first. So when you before you start with the titration process, injection metoclopramide 10 milligram is given stat because this is the immediate side effect that you can expect on intravenous morphine administration. So injection metoclopramide 10 milligram is given stat and followed by that you can, so suppose a patient is started on morphine titration and at 10 o'clock the patient is started on morphine titration. Record the vitals of the patient, including the pulse rate, respiratory rate, and BP. And the most important is the pain score. So the patient who has presented to us is on 10 on 10 pain. Is not drowsy. So mention the drowsy, whether the patient is drowsy or not. And At 10 o'clock, 1.5 milligram of IV morphine is given to the patient. Wait for 10 minutes and reassess the pain score. After 10 minutes, reassess the pain score. The pain score has, and recheck the vitals. Pain score has come down to 7 now. Patient is still not drowsy. Then go for another 1 ml of IV morphine. So again, a 1.5 milligram of IV morphine is given. Wait for another 10 minutes and by 10:20, recheck the vitals and reassess the pain score. Now the pain score in this patient has come down to 4/10. The patient is still not drowsy. And injection, so another dose of injection morphine, 1 ml of injection morphine is given to the patient. Wait for another 10 minutes and by 10:30, after 10 minutes, reassess the vitals. And now the pain score has come down to 1. Still the patient is not drowsy. So the pain relief has become satisfactory now. So that is the endpoint of the morphine titration in this patient. So we are stopping the titration here. So a total of 4.5 milligram of injection morphine is being given to the patient in 10 minutes interval. 1.5 milligram in every 10 minutes interval. And the most, apart from recording the vitals, the most important is to record the pain score of the patient and the drowsiness of the patient. And the endpoint of the titration would be either the patient has a satisfactory pain relief or the drowsy patient becomes drowsy, whichever happens first. Hope this is clear to you. Do you want me to repeat this or is this clear to you? Intravenous morphine titration process? Okay. So the 1 ampule of morphine contains 15 milligram of morphine. So 1 ampule is diluted with 9 ml of diluent in such a way that 10 ml of morphine contains 15 milligram. So that 1 ml contains 1.5 milligram of injection morphine. And this 1 ml of injection morphine is given every 10 minutes. Before starting the morphine titration process, give the patient injection metoclopramide as the expected immediate side effect on morphine administration. Intravenous morphine administration is nausea and vomiting. So injection metoclopramide, 10 milligram stat is given. And after that, we start with the morphine titration, record the vitals, including the pain score, and see if the patient is drowsy, and then start with the titration process. 1.5 milligram of IV morphine given every 10 minutes. And the endpoint of the titration would be either the pain score comes down and patient has satisfactory pain relief or the patient becomes drowsy. Whichever happens first would be the endpoint of the titration. So this patient, now we know that with 4.5 milligram of IV morphine, the patient has got satisfactory pain relief. Now we want to send this patient home. What is the option? We need to convert this intravenous morphine to oral morphine. Yes, oral morphine would be the option. So the conversion ratio is 1:1. This is for intravenous morphine titration. The conversion ratio is 1:1 conversion. So the patient is on 4.5 milligram of intravenous morphine. We convert it to 5 milligram of oral morphine tablet. So we have 10 milligram morphine tablets available. So we convert the patient to 5 milligram of oral morphine. So the patient's prescription would look like 5 milligram tab morphine 10 mg or 5 milligram of morphine every 4 hourly would be the prescription. Q4H. Tab morphine 5 milligram Q4H and 10 milligram at bedtime and 5 milligram as SOS dose as and when required. So this would be the prescription pattern. So 5 milligram at 6 a.m. or when the patient wakes up, 10 a.m., 2 p.m., 6 p.m. and at bedtime, and the same 5 milligram as SOS dose if the patient has pain in between. Why do you want to give double dose at bedtime? Yes. Yeah. Thank you for, yes, we don't want to wake up the patient. So if we give the patient around 10 p.m. the night dose, obviously the next dosing would be at 2 a.m. And we don't want to wake up the patient at 2 a.m. and give an additional dose. And we want to maintain the steady dose of morphine in the blood throughout the night. For this, we are giving double dose at bedtime so that the patient has adequate pain relief during the night time till he wakes up in the morning. So that is why a double dose is being given to the patient at night. Suppose we don't have injection morphine, then how do we go about? We only have oral morphine preparations with us, then how do we go about? So that is oral morphine titration. We can do oral morphine titration for the patient. So if it is, yes, so yeah, so regarding, so Dr. Victoria is asking about the antiemetic. Yes, antiemetic needs to be prescribed along with morphine at least for first 3 days. You need to give tab metoclopramide 10 milligram 8 hourly for at least first 3 days. We have to prescribe along with the oral morphine. And suppose we are the patient, we don't have an IV preparation or an ampule with us, and we are only have oral morphine with us. Then we'll start, if it is a patient who is new to opioid, we'll start with 5 milligram of oral morphine every 4 hourly, 10 milligram at night, and 5 milligram as SOS dose. And if the patient is on weak opioids like tramadol or tapentadol, we start the patient with 10 milligram of oral morphine every 4 hourly and 20 milligram at night, and 10 milligram as SOS dose. So that is oral morphine titration. So now moving on to our story. So we had a patient who has come to us on severe pain, 10 on 10 pain, and we had did a morphine, intravenous morphine titration for him, and we found that 4.5 milligram of intravenous morphine was essential for adequate pain relief in that, satisfactory pain relief in that patient. And to send him home, we converted it to tab morphine 5 milligram Q4H and 10 milligram at night dose and 5 milligram as SOS dose. And this patient was having adequate pain relief for 2 weeks. But since the last 4 days, he was using 3 SOS dose of morphine per day. What shall we do now? What do you think? How can we handle this situation? So initially he was having adequate pain relief, but since 4 days he's taking SOS dose of morphine, 3 doses per day. What does that indicate? Yes. So there are breakthrough pains coming in between, which indicate that the dosage is insufficient and the dose needs to be readjusted. How do we readjust the dose? So in such situations where more than 2 to 3 doses of rescue morphine is needed in a 24 hours time, we have to increase the dose by 30 to 50%. So for this patient, we can either increase the dose from 5 milligram Q4H to 7.5 or 10 milligram Q4H. So as the dose is insufficient, 30 to 50% increase every 24 hours. 30 to 50% increase is what is needed here to ensure adequate satisfactory pain relief for this patient. So we said, so now we can increase the dose. But how frequently would you give the SOS dose of oral morphine? So I already told that I was repeatedly telling in every situations to give SOS dose of morphine, SOS dose of morphine. But how frequently can we use SOS dose of oral morphine? Any comments? Any responses on that? How frequent can we give this SOS dose of morphine? Yes. So Dr. Adira says that after 60 minutes. So Dr. Adira, would you like to unmute and talk more about it? Why you want to give after 60 minutes?
Hello, ma'am. The peak level of activity of the oral morphine is usually 60 minutes. So we will ask the patient if there is pain after 60 minutes, you can take an SOS dose.
Yes, exactly. Thank you. Thank you, Adira, for that
Thank you,
response. So to understand this more, we need to know more about morphine. So morphine, it is a naturally occurring alkaloid. So morphine is a naturally occurring opioid and it is extracted from the pod of a seed of poppy plant called Papaver somniferum. So Papaver means, it is a Greek word for poppy, and somniferum in Latin means sleep inducing. So this morphine is legally permitted to be cultivated in 3 states in India: Uttar Pradesh, Rajasthan, and Madhya Pradesh are the 3 states in India with legal permission for cultivation of morphine. And moving on to the pharmacokinetics of morphine. Morphine, it is a weak base, and when taken orally, it is absorbed mostly from the upper part of the small intestine. It is hydrophilic in nature, so it is slow in onset and has longer duration of action. The sublingual absorption rate is low, and the research shows that buccal and gingival absorptions are very much variable. The rate of absorption is very much variable, and morphine has got a bitter taste. Moving on to the metabolism of morphine. So when morphine is taken orally, it reaches the gastrointestinal tract and it is absorbed into the blood vessels, and it reaches through the portal vein circulation, it reaches the liver and it undergoes metabolism in the liver. And morphine undergoes glucuronidation in the liver and its metabolites are released into the systemic circulation. The majority of metabolism of morphine takes place in the liver, but metabolism also takes place in the gastrointestinal tract as well as in the kidney. And 90% of morphine gets converted to its metabolites. And the metabolites of morphine are morphine 6-glucuronide and morphine 3-glucuronide. This morphine 6-glucuronide, which is around 5 to 10% of the metabolites, is responsible for the analgesic effect of morphine. So this morphine 6-glucuronide produces the analgesic effect. And morphine 3-glucuronide is responsible for the neurotoxic effects of morphine. So this whole process of morphine reaching the liver and getting metabolized by glucuronidation and converting to its metabolites, it takes around 45 minutes to 60 minutes. So morphine, to produce its peak analgesic effect, it takes around 1 hour to produce its peak analgesic effect. And as Dr. Adira said, there should be a gap of at least 1 hour between the rescue dose or SOS dose of morphine. So once morphine is taken, we have to advise the patients that there should be a gap of minimum 1 hour between two rescue doses of morphine. This is because it takes around 45 to 60 minutes for the morphine to produce its peak analgesic effect in the blood. And even after the 60 minutes, if the patient is not having adequate pain relief with morphine, you can ask the patient to take one more dose of morphine or an SOS dose of morphine. So now, moving on, this patient who was on 10 milligram of morphine 4 hourly, he finds it very difficult to take it every 4 hourly. He understands that it is important to take this medication to be pain-free, but he requests if this can be given less frequently. What can be done? How will we go about this? Yes. Thank you, Dr. Adira, for that response. So the patient, we can convert the immediate release preparation to sustained release preparations. So sustained release morphine is available and the duration of action. So immediate release preparation, you said you have already seen that we are prescribing it every 4 hours. The duration of action of sustained release preparation is 12 hours. So for this patient who is on 10 milligram of oral morphine Q4H, that means the patient is taking around 60 milligram in 24 hours. The patient can be converted to 30 milligram of SR morphine twice daily. So the patient does not have to take it that frequently, only twice daily the patient needs to take it. So there are other preparations of morphine available. Morphine is available in aqueous solutions as syrup form. There are immediate release tablets as well as sustained release tablets, and injectable form of morphine is available. Moving on. So the patient who was on 10 milligram of morphine 4 hourly for the past 6 months, he was brought to you with excessive drowsiness. And on examination, it was found that his serum creatinine was 5 milligram per deciliter. Will you do anything with the morphine dosage? So we have a question in the chat box. SR preparation is so effective, why not give it to everyone? So the SR preparation is effective, but it is cost of preparation is on a higher side, and also only if the patient is having stable pain relief. Like once you arrive at a dose that the patient has adequate pain relief with 10 milligram of oral morphine every 4 hourly, you can arrive at a conclusion the total dose required in a day. And then if the patient is not needing any breakthrough dose in between, you can convert it to sustained release preparations. Yes, sustained release preparation is an option, but only if the patient is not requiring any breakthrough doses in between. So now coming back to this patient scenario, so the patient is presenting to you with excessive drowsiness. Modify the dose. Okay. Why do you want to modify the dose? So Dr. Shruti says that there is no need for the modification of dose. Any other responses? So we'll discuss more on this. For this, we need to know the excretion of morphine. So morphine is excreted from the body by glomerular filtration. So what happens in patients with, so here the serum creatinine is increased. The patients in renal failure, what happens is that morphine 6-glucuronide accumulates in the blood and its half-life gets prolonged as the clearance is decreased. So even with lesser doses or less frequent doses, it can produce satisfactory analgesia. So we can modify the dose. We can either increase the spacing and make the dose thrice daily or 6 hourly, or you can reduce the dose or go for alternative opioids which are more renally safe. So since the excretion is through kidney by glomerular filtration, there will be accumulation of morphine metabolites when in patients with renal failure. And when there is accumulation of morphine, we need to prescribe only less frequent doses, or you can reduce the dose as such, and or you can try for alternative opioids as the clearance is decreased. So for this patient, what will you do now for pain relief? Oh, sorry, this is another patient scenario where the patient was sent home, and right now, so we are already seeing that we are reducing the dose as well as we have reduced the frequency. So the patient is currently on 5 milligram of oral morphine every 8 hourly, and but after 2 months, the patient is deteriorating and is unable to swallow anything, including morphine. So what will you do now for pain relief? So the patient, transdermal patch, yes. Subcutaneous, go back to IV. Yes, there are different options. Thank you all for the responses. Yes, there are different options when the patient is unable to swallow. So usually if the patient is in a home care setting, what we usually prefer as a first line choice would be to understand this better more, we need to know about the routes of morphine administration. So morphine can be administered orally. As I already mentioned, oral route is the best route, preferred route for as per the principles of analgesic use. It can also be given through intravenous route or subcutaneous route, or rectally it can be given through epidural route, intrathecal route. So these are the different routes of administering morphine. So coming back to the patient scenario, anybody has any other suggestions on how to handle this patient when he is at home and unable to swallow anything? So we have already seen the different preparations of morphine. Yes. Yes, fentanyl patch could be a choice, but there it is very expensive, fentanyl patch. Per rectal preparation, yes, Dr. Victoria, per rectal preparation would be a best choice. So the same oral morphine, it can be like the 10 milligram tablet, half of the 10 milligram tablet, that oral morphine tablet, it can be one drop of water can be added to it and made into a paste, and it can be applied onto the rectal mucosa. The absorption rate is almost comparable like that of the oral preparation. So the patient can be started on 5 milligram of per rectal 8 hourly. The same oral tablet can be given per rectally 8 hourly. So moving on to another patient story. So we have a 55-year-old lady with carcinoma of colon. She has abdominal pain which is continuous in nature and is on 10 milligram of oral morphine every 4 hourly. And she is having well-controlled pain relief with this medication and not requiring any SOS dose of morphine. So now the doctor has asked them to replace morphine with 25 microgram of fentanyl patch. So the next day, the patient report to you telling that they replaced fentanyl patch after 5 hours as she had no pain relief. What will you do? Yes, there have changed. Yeah, there have been different responses regarding the fentanyl patch. Fentanyl peak 7 comes after 24 hours. So it takes at least 24 hours for action. Thank you. Thank you for all the responses. So we'll be looking into fentanyl. So fentanyl, it is a synthetic opioid, and it is also a it is a synthetic opioid, and the preparations, it is available as in injectable form. Then it is available as transdermal patches, and it is also available as lozenges, oral transmucosal fentanyl citrate. It is lipophilic in nature, and it is 100 to 150 times more potent than morphine. That is 60 milligram of oral morphine equivalent in a day is equal to 25 microgram per hour of fentanyl patch. So when we say 25 microgram of fentanyl patch, it means that 25 microgram per hour of fentanyl is being released into the blood. So this is regarding fentanyl, and regarding the fentanyl patch, how does fentanyl patch acts? It forms a subcutaneous depot of the drug, and this is slowly released into the circulation. And effective analgesia is obtained only after 8 to 12 hours of the application of the patch. Usually when fentanyl patch is applied, care should be taken that it should be in the intact skin, not on hairy skin, and the skin should not be shaved of hairs, because there could be micro abrasions which can affect the absorption of fentanyl. So it should always be applied to intact skin. And heat, sweating, all this can affect the absorption of fentanyl. And when you use a fentanyl patch, it acts for 3 days. So a fentanyl patch, when usually kept, it releases 20, if it is a 25 microgram patch, it releases 25 microgram per hour of fentanyl for 72 hours. A single patch can last for 72 hours. And as I said, and the most important is that fentanyl patch can be used only for patients with stable pain control. So in our patient, it was already mentioned that the patient is not requiring any SOS dose of morphine. So it means that the patient has adequate pain relief or satisfactory pain relief with the current medications. This is because once the fentanyl patch is on, we don't have any control over the release of the fentanyl. So if there is breakthrough pain, it will be difficult to manage. So it is always preferable to use fentanyl transdermal patch only for stable pain. So now we have another patient, a 70-year-old man who has a carcinoma of lung and is complaining of throbbing pain on the right front of the chest, which is a continuous pain with a score of 5/10. And he is a non-epileptic and is on levetiracetam 500 milligram BD. How will you manage his pain? So, which would be the right opioid for this patient? Any responses? We have a 70-year-old man with carcinoma of lung with a continuous throbbing kind of pain with a score of 5/10 intensity. And he is a non-epileptic and is on levetiracetam 500 milligram BD. How will you manage his pain? We have multiple answers coming up. Fentanyl, tramadol. Any more responses? Morphine. Morphine. Dr. Adira, would you like to unmute and say why morphine? Anybody? Yes, exactly. Just a reminder on that. Dr. Gauri has already put in that tramadol can provoke seizure. So the patient is it's an epileptic patient and is already on anti-epileptics, and we know that tramadol is so depending upon the severity of the pain, the patient has a moderate pain. So the ideal would be step 2 of the WHO analgesic ladder, which would be tramadol or tapentadol. But tramadol as well as tapentadol can reduce the seizure threshold. So it is always preferable in such patients to start with a low dose of morphine. So ideal would be 5 milligram of oral morphine every 4 hourly and 10 milligram at night and 5 milligram as SOS dose would be the ideal start of opioid of choice for this patient. Keeping in mind that step 2 opioids that are available, tramadol, tapentadol, can reduce the seizure threshold, and the patient can, it would be good for a patient on anti-epileptics and prone to develop seizures. So just a reminder on that. So moving on. So to know more about what are opioids. So opioids are, they can be naturally occurring, semi-synthetic and synthetic drugs, and they usually produce their effects. So basically there are 2 characteristics for opioids. Opioids are drugs that produce their effects by combining with the opioid receptors, and their actions are reversed by naloxone. So stereospecifically, they are antagonized by naloxone. So opioids can be either naturally occurring, semi-synthetic or synthetic drugs. And the 2 characteristics of opioids or a drug to be called opioid, it has to produce its effect by combining with the opioid receptor, and its action should be antagonized or reversed by naloxone. So these are the 2 characteristics of opioids. So what are opioid receptors? Receptors of opioids are mu, kappa, delta, and sigma. Sigma is not a true opioid receptor because its action, the action mediated through it is not reversed by naloxone. So it is not a true opioid receptor. We have already said that opioids, the characteristics of opioid drugs are that either their action is mediated by, they act by combining with the opioid receptors, and their action can be reversed by the naloxone or antagonized by naloxone. And the opioid receptors are mu, kappa, and delta. And opioid, depending upon the receptor interactions, the opioids are classified into agonist, antagonist, and agonist-antagonist. What is an agonist drug? So an agonist drug is a drug that combines with the receptor site and produces its effect. So it has high affinity for the receptor site, and combining with the receptor site, it produces its effect. For example, morphine is a mu agonist. That means that morphine binds with the mu receptors and produces its analgesic effect. That is the agonist drug. What is an antagonist? An antagonist is a drug that combines with the receptor site and prevents the agonist from combining the site. So antagonist as such does not have any effect. It does not produce any effect, but in turn it does not allow the agonist drug to bind with the receptor site and produce its action. For example, naloxone is a antagonist, is a morphine antagonist. It's an opioid antagonist. What does naloxone do? So it displaces morphine from the mu receptor site and it binds with the mu receptor site and antagonizes the action of morphine or opioids. So that is an antagonist. And what is agonist-antagonist? So some drugs, they are acted certain receptors as agonist and certain other receptors as antagonist. That is agonist-antagonist. So an agonist drug, if you keep on increasing the dose of the agonist drug, the pain relief keeps on improving. So the patient will have improved pain relief. That means that there is no ceiling effect. So if you keep on increasing the dose of the medication, the pain relief also becomes satisfactory and pain relief improves. But for an agonist-antagonist drug, beyond a point, if you keep on increasing the dose, the pain relief also improves. But beyond a certain dose, if you increase the dose of the medication or the drug, the pain relief will not increase. The pain relief will be in the same level. The pain relief will not increase. That is agonist-antagonist. And we have another group of drugs called mixed agonist-antagonist. An example is pendazoxine. So pendazoxine, it is an agonist-antagonist. That means that in kappa receptors, it has an agonistic effect, whereas it is a weak antagonist at mu receptors. So morphine is a mu agonist. That means that morphine always binds with the mu receptor to produce its analgesic effect. So if pendazoxine is given along with morphine to a patient who is on morphine, what does pendazoxine do? It replaces morphine from the mu receptors because it has an antagonistic effect at the mu receptor site. So that is agonist-antagonist. Now, what does the side effects of morphine? Can someone talk about the side effects of morphine? So side effects. So the adverse effects can be classified as side effects and toxic effects. What are side effects? Side effects means the adverse effects that happens even with the therapeutic dose. So that is called side effects. And toxic effects means that if the dose is higher than that is required for adequate pain relief, that is toxic effects. Such doses produces toxic effects. Yes. So the side effects of morphine include constipation, nausea, vomiting, constipation, yes. Yes. Thank you all for the response. The most common side effect of morphine is constipation. Around 90% to 95% of patients on morphine are likely to develop constipation. And this might be present as long as the patient is on the opioid, the patient will have constipation. So, keeping this in mind, whenever we start a patient on morphine, a stimulant laxative should be prescribed. So, the morphine, along with morphine prescription, we need to add a stimulant laxative to prevent this constipation. So, regular stimulant laxatives could be bisacodyl, sodium picosulfate, sodium picosulfate could be the stimulant laxatives that can be prescribed along with morphine to prevent constipation. And nausea and vomiting, sleepiness and tiredness, itching, dry mouth, urinary hesitancy. These are some of the side effects of morphine with the therapeutic dose. So, as I mentioned, around 95% of the patients have this constipation, and we need to start with stimulant laxatives. Vomiting and nausea and vomiting, this is the self-limiting symptom. Self-limiting, it occurs in 1/3 of the patients in first few days, and after this 2 to 3 days, this symptom will subside by itself. So, when we start a patient on morphine, we need to prescribe an antiemetic for the first 3 days. And how does this vomiting and nausea happen? So, this is due to the stimulation of the chemoreceptor trigger zone. So, the drugs acting on the chemoreceptor trigger zone like metoclopramide, haloperidol, domperidone, etc. are being prescribed along with morphine. So when we start a patient on tab morphine, suppose we start a patient on tab morphine 5 milligram Q4H, 10 milligram at bedtime, and 5 milligram as SOS. Along with that, we have to start tab metoclopramide 10 milligram 8 hourly for 3 days. For 2 to 3 days. And of course, tab bisacodyl or sodium picosulfate 10 milligram HS dose is also needed. So for the laxatives need to be continued as long as the patient is on the opioid, but antiemetics can be stopped after 2 to 3 days. Then next is another symptom is the sleepiness and tiredness. So whenever you start a patient, around 1/3 of the patient on initiation of the treatment is likely to develop sleepiness and tiredness. So when we start a patient, we need to tell the patient that you are likely to feel sleepy and tiredness. So if this doesn't get over in 2 to 3 days, please report to us. So this need to be informed to the patient. Unless we clearly inform the patient about this, the compliance would be an issue. After starting on morphine, if the patient feels nauseated and they are not taking the antiemetic, they will not continue the medication and will remain in pain. And if we do not inform them about the possibility of sleepiness and tiredness, after one dose, the patient might be feeling very sleepy and they think that there is something, they'll be worried about it and they might not continue with the dose. So it's very important to inform the patient about the side effects. So what are the toxic effects? So the adverse effect when it is administered when the administered dose is higher than that is required for pain relief, or if the pain is not opioid sensitive, then the patient may result in toxicities. And the common toxic effects include delirium, irrelevant talk, myoclonus, jerky movements. The patient may report jerky movements, and drowsiness. Here, the drowsiness would be extended drowsiness. So these are the toxic effects of morphine. Does opioid produces respiratory depression? So I saw in the chat box also there were a few responses telling respiratory depression. At toxic doses, opioids might produce respiratory depression. Yes, but if the medications are given orally and they are properly monitored and the doses are titrated with cautious monitoring, respiratory depression is very unusual. I have been in the palliative care field since 10 years, and I have never seen a patient who developed respiratory depression on oral morphine. It is very less likely to develop, provided you titrate the dose, monitoring the toxic effects, and also there is a gradual increase in the dose. So it is very less likely to develop respiratory depression. And even the Journal of Pain, the paper also says that this is a quoting from that paper which says that such respiratory depression as a side effect is very less likely to happen if it is properly monitored and given. And when can this respiratory compromise occur? So it can occur if there is some underlying pneumonia, pulmonary embolism, or cardiomyopathy associated with it, or if the patient is undergoing any sedative medicines or any benzodiazepines the patient is already on. Such situations, this respiratory compromise can occur. Dr. Gauri, to my experience, respiratory depression is very unusual in intravenous morphine titration. This is because we are giving the medication every 10 minutes with proper monitoring of the pain score as well as the drowsiness. So we are monitoring the toxic effects as well as the response to the pain. So if the intravenous morphine titration is done under proper monitoring, I don't think there is any chance of respiratory depression. Thus, opioids cause addiction. How many of you are using morphine now? I mean, opioids, any opioids? I think Dr. Amirtha is using.
Yes, ma'am. We have a palliative care unit.
Yes, Dr. Amirtha, you are from?
From Ottapalam, ma'am.
Oh.
Palakkad.
Oh. So you do intravenous morphine titration also?
No, ma'am. We have no intravenous titration. Only oral morphine is available.
Have you seen any patients on respiratory depression or?
No, ma'am. No, ma'am.
Okay. Thank you, Dr. Amirtha. Anybody? Anyone else is using morphine, oral morphine or fentanyl? Okay, Dr. Gauri?
Yes, ma'am.
Yes. Do you do intravenous morphine titration at your place?
Only once we have done, ma'am. So then also there was no respiratory depression, but I was just curious.
Yeah. So it is very less likely, Dr. Gauri. If we are monitoring properly and we are confident in using, then such chances are very less. Does opioid causes addiction? So let's see what the literature says. So the substance abuse as a result of medical use is very low. So as per the literature, when opioids are prescribed for medical use, there are very less chance of substance abuse. And there is always a confusion between physical dependence and psychological dependence. And another serious issue is the overestimation of risk of addiction. So even the physicians are afraid or they overestimate the risk of addiction and as a result of that, the usage of opioids are limited or they restrict the use of opioids fearing that addiction might occur. And this will result in more sufferings to the patients. We are unable to meet the needs of needy patients or reduce the suffering of the needy patients because of our overestimation of risk of addiction. So that is what the literature says. So there is always a confusion between psychological dependence or addiction and physical dependence. So according to the American Academy of Pain Medicine and the American Pain Society, psychological dependence, it is the primary chronic neurobiologic disease with genetic, psychosocial and environmental factors influencing its development and manifestations. So there is impaired control over the drug use, there is compulsive use and continued use despite harm and craving. So this is the definition the American Academy of Pain Medicine has given for psychological dependence or addiction. And what is physical dependence? It is a state of adaptation that is manifested by a drug class specific withdrawal symptom. How many of you drink tea or coffee in the morning? Can I have your hands raised? How many of you drink tea or coffee in the morning? So Dr. Victoria says yes, yes, yes. So what will happen if you don't drink tea or coffee in the morning? Yeah, so many people are drinking tea or coffee. Okay. So Dr. Adira says that she gets headache. Yeah, so many are having headache. Okay. Yes. So Dr. Suma says that alertness is less. So suppose Dr. Adira, she's used to drinking tea in the morning. I'm sorry, I'm taking you as an example.
No problem.
So Dr. Adira does not have tea leaves today. Every day she's used to drink tea in the morning, but unfortunately today there is no tea leaves in her house. But Dr. Sheetal lives nearby, and she knows that, like, she's in the next flat. She knows that Dr. Sheetal has tea leaves at her home, in her kitchen. But unfortunately, Dr. Sheetal is not there in the flat. Her house is locked. So what Dr. Adira does is that she breaks open Dr. Sheetal's kitchen and get into her kitchen and get the tea leaves and prepare the tea and drink. What is that? So that is psychological dependence. So in spite knowing that this is harm, she shouldn't be doing this, she has no control over herself and she's craving to have that and she is doing it. So that is psychological dependence. And you have been giving your body since long, many years you have been used to giving tea to your body. And today suddenly you say there is no tea. So the body will react to it in the form of headache, alertness, less energy. That is some withdrawal syndrome or withdrawal symptoms showing that the body is responding, telling that I need tea. That is physical dependence. This is just to put it simply in simple words, what is psychological dependence and what is physical dependence. I hope it made some sense to you. So now, just to give you a comparative cost of opioids. So there were many suggestions in between telling me that, so we can convert to fentanyl patch, we can go for, so just to understand, whenever you prescribe an opioid, be aware of the price. Like 5 milligram of oral morphine every 4 hourly. That is 30 milligram in a day. Its cost is around 3 rupees 50 paise. And the equipotent dose of tramadol, which is 300 milligram, cost is around 24 to 50 rupees per day. And equipotent dose of fentanyl patch, around 12.5 microgram, is 250 to 400 rupees per day. 250 to 400 rupees per patch. And buprenorphine patch, 10 microgram, which is the equipotent dose is 10 microgram, which is around 1920 rupees. And that of methadone, 5 milligram of methadone, the cost is only 4.50. So this is just to give you an idea. When you prescribe, please look into the socioeconomic status of the patient also before giving the prescriptions and make sure that we also play a vital role in ensuring the compliance. If a patient is not affordable and we are trying to stabilize, the patient is on stable pain relief and try to convert to fentanyl patch, the patient might not be able to afford it. So just to give you an overview of the cost of opioids. Yes, with that, I think I've come to the closure of my session.
Thank you, ma'am. Thank you for your wonderful session. If you have any doubts, you can unmute yourself and ask, or you can put it in the chat box. there is nothing, we can move on to the case presentation. Your case presentation is Dr. Amirtha Thampi. Welcome to the case presentation. Okay.
May I start, sir?
Please go ahead, Dr. Adira.
Good evening, everyone. Myself, Adira. I am working at a early cancer detection center in THQS Education-Pallium. We have a palliative care unit. So along with that, I am able to prescribe some amount of morphine tablet to my patients. Next slide, sir. So here is a case of 42-year male patient. He was diagnosed with squamous cell carcinoma of gingivo-buccal complex, lower mandibular area, which is a recurrence case. Okay. Currently complaint of persistent pain over the lower jaw since 3 weeks. And he having the pain since 3 months. And since 3 weeks, he having persistent dull aching pain. It starts in the lower jaw and radiates to ear, forehead, temporal area, neck region of the left side. And he having constant pain with flares of sharp shooting pain, especially during night and few times during the daytime. So he is complaining of tiredness during the day due to decreased sleep, having a pain score of 6/10 with flares up to 10/10, and which is worse during the while he lay down and while eating, and even he's a businessman, so he complains that he hurt even while speaking. The pain is not relieved with current analgesics, and he had multiple visits to casualty due to severe pain. So coming to his history of illness, he is actually a known case of squamous cell carcinoma of left buccal mucosa, diagnosed in 2021, and had undergone 15 cycles of radiation and 4 cycles of chemotherapy with injection cisplatin 3 weekly, and he was on regular follow-up. And 3 months back, he had a ulcer at the same site with discharge from the chin area. So again, biopsy was done and it was turned to be a recurrence. And currently he is under injection methotrexate 2 weekly and plan to undergo a surgery after the chemotherapy. And he was on tramadol 50 mg TID, paracetamol 500 mg TID, and amitriptyline 25 milligram half HS for the pain after the biopsy. But since 3 weeks, these medications are not effective for him, and he was even taking over-the-counter analgesics. From general examination, he was conscious, oriented, moderately built and nourished, normal gait and erect posture. There was no pallor, icterus, cyanosis or clubbing. Lymph nodes were palpable at submental and submandibular region, and there is slight lymphedema near the submental and submandibular region. The vitals were within normal limit, and other systemic examination were, there was no abnormality detected clinically on inspection, palpation and auscultation. Coming to extraoral examination, there was erythema of the submental and submandibular region. On palpation, the region were tender, and there was palpable submental and submandibular lymph node of approximately 2 × 2 centimeter, which was firm to bony hardened consistency. And near the submandibular lymph node, there were fixity was noted. Intraoral examination, the interincisal mouth opening was only 30 mm. The buccal mucosa were non-resilient and with a blanched appearance. There were vertical bands, and there was ulceroproliferative lesion of approximately 2 × 2.5 centimeter along the buccal vestibule and gingiva of the mandibular second premolar, along the buccal vestibule of residual alveolar ridge of first molar region, which is extending over to the ridge area. On palpation, lesions were tender. There was no provoked or spontaneous bleeding at the area. Already he has radiation caries and xerostomia was there. There were no pressure sores. Coming to routine investigation, the routine blood examination were within normal limits. RFT and LFT were within normal limits. CCT explained the extent of lesion. Even there is erosion of the mandible was there with metastatic lymphadenopathy. So he was treated. There are slight erythema and edema of the submental and submandibular region indicating slight of infection. So he was treated with a course of antibiotic, moxiclav and metronidazole, and even given with a Dexona 4 mg BD as a anti-inflammatory agent. He was familiar with salt and baking soda rinse, so he was continuing that. And along with that, the pain regimen was altered into tab morphine 10 mg fourth hourly. Actually, this SOS, it is a typing mistake. It is only half SOS. So half, and then at a single dose at the night. And along with that, he is asked to continue the amitriptyline 25 mg half HS dose, and also prescribed omeprazole and domperidone along with that. And he's also given a prescription of tab-bisacodyl 5 mg 2HS as a prophylaxis for the constipation, and advised to increase the frequency of water intaking, and also oral hygiene instructions were given. From psychosocial aspect, he is a businessman living with wife and 3 children, and he is religious, ex-Betelgeuse and Pan Masala user for 15 years. He used for 8 years. Middle socioeconomic status, concerned about the recurrence, and is very anxious to undergo a surgery after the chemotherapy, and showing anger issue towards the wife and children because of his pain, and concerned about disturbing the sleep of wife during the night times. His main concern were persistent pain, concern about the family members and the quality of life, concern about recurrence and undergoing a surgery. And because it is a recurrence, he is again asking about what is the success of the treatment. Coming to summary, he's 42-year-old male patient with pain in the lower jaw since 3 weeks, diagnosed case of buccal mucosa, had undergone chemo and RT, recurrence diagnosed 3 months back and on chemotherapy and planned for surgery. Currently, he was managed with oral antibiotic, anti-inflammatory drugs, and oral morphine was added to his pain regimen. Discussion points, discuss about the management of the pain, how to address the total pain in this patient, how to discuss about adding morphine for pain management to family members, and question regarding its availability and safety use of the drug. Thank you.
Thank you. Thank you, Dr. Amirtha, for bringing this patient story up. And this is a very much suited story related to the topic being discussed today. So I would request the participants to actively give in your inputs. How can we help Dr. Amirtha take forward this patient? So the first point is, how about the management of pain? Requesting inputs from the participants. You can either unmute and talk, or you can type in your chat box. No comments? Why? What happened? Why not NSAIDs? So, Dr. Sundaram, can you unmute and talk?
Yeah, since the patient is young, around 42 years, and he has been prescribed morphine, why not add NSAID so that because there is inflammation also being oral cavity, it should be helpful.
Dr. Adira, you want to say something on that?
Actually, he is experiencing a chronic pain, okay, which is both somatic and a neuropathic type of pain, that is dull aching and sharp shooting type. So, and he's already taken multiple over the counter of analgesics. Okay, so already on method undergoing a chemotherapy. So we should be concerned about the renal aspect also. And also the moderate to severe pain. He's experiencing moderate to severe pain. It's not a mild pain. That is why we started with morphine. Even first thought about adding a increased dose of tramadol, but further discussing with him, and also his anxiety and severe family issue and all. So we just started with morphine directly.
Any more responses? Anybody wants to add anything to that?
Is the pain controlled with the addition of morphine or not?
Yes, we contacted him after 3 days. 3 days after, his wife contacted to our department and told that he is better now and experiencing only a pain of about 3. That is under a numeric of 3 only now experiencing. He is much better and he is able to take, he is able to eat his food and all. So he with the conversation, they were much happier, and he's coming for review in this Thursday only.
You have done well. So I think we should continue that, is it not?
And he taken only 2 days. He had to take an extra dose of 2.
Yeah. Yes.
To control the breakthrough pain.
Okay. So thank you so much, Dr. Atira, for bringing this patient up. So I see in the history that steroid was already attempted, and you have put it very well. The pain presentation, you have put it, it is more of a somatic, nociceptive kind of pain and with the neuropathic component in it. So it can respond well to the opioids as well as tricyclic antidepressants, and you are already on the right path. So I would suggest this patient, he is only on 5 milligram of oral morphine every 4 hourly. You can very well increase the dose if pain relief was not adequate. And if the neuropathic component is on a higher side, you can also think about increasing the dose of tricyclic antidepressants. Right now, he's only on 12.5 milligram of amitriptyline, I think.
Yes, ma'am.
So you can increase to 25 milligram. Has he presented with any toxic signs of opioid like morphine?
No, ma'am. Initially, he was slightly sleepy and all, but later she told that he's okay. No much complications or noted.
So how did you discuss about this morphine to the family, Dr. Adit? I would like to hear it from you, because even the many healthcare professionals are confused. Like, would morphine be the patient is a young patient, would this be a right choice for this patient? So you have already attempted on step 1 and step 2, and the patient was suffering a lot and you took the right decision of adding or starting with the step 3 opioids. But how did you inform or convince the family? And how did you communicate to the family? What are the precautions? Could you please elaborate on that, Dr. Adira, for all the participants to hear?
Okay, ma'am. First of all, usually he comes along with his wife. So both of them were not anxious about starting morphine. But I told them it's in case of cancer or non-cancerous illness, in case of chronic pain, if it is not subsided by usual analgesics, which have severe systemic side effects. So all the patients, so usually we will be starting with the morphine doses, and they are not much knowledgeable about morphine abuse or addiction and all. So there were no questions from their side and all. But we explained that usually it will have he can develop a craving for morphine. So we have to give only the specific dose. That is, if there is pain relief, you should not take extra doses, and you should always bring the bottle. Okay, how many tablets you have taken? So we have to confirm that you are not taking extra doses, or there is no missing tablets, and there is small children in the home. So it should be well kept, should not be available to child. And it is a responsibility from their part to do like this. Then there will be some complications like nausea, vomiting. There will be constipation. So we are giving medication for these symptoms. And if you have any concerns, you can contact us directly through the phone, or come for a review. And they are okay with all that and all.
Thank you, Dr. Adira. Very well handled. So this is usually how, when we prescribe opioids for a patient, first of all, we need to inform them that the side effects with NSAIDs or the renal compromise that might happen on long-term use of NSAIDs will not occur with opioids or with morphine. And what they need to monitor would be the toxic effects, and what they need to manage would be the side effects that might occur. The side effects like constipation, which we should educate them, telling them that the laxatives need to be continued, not to stop the laxatives as long as the patient is on the morphine. And regarding the antiemetics, at least for the first 3 days, continue with the antiemetics and make sure that the patient do continue with the medications. If we don't educate them on all this, the patient might back out at any point of time. And also the chances of toxicities. There are chances of drowsiness developing, but if the drowsiness is beyond a point where the patient sleeps over, after one dose, if the patient is sleeping for 4 hours till the next dose, then there need to be an alert. They need to be alert and see that there are some chances of toxicities setting in. Such situations, they need to inform us, and we might need to. So in such situations also, what we'll either skip the next dose and try to reduce the dose. So that would be what we'll be focusing on, not to withdraw the medications if it is responding to more pain. So that is, if it is an opioid sensitive pain responding, then that would be the ideal way of titrating the dose. And also what Dr. Adira has mentioned, this medication should not be taken by other people in the home for any kinds of pain. It should not be, it should be kept away from the reach of children. All this need to be explained to them well, and always provide a contact number whenever they have any doubts they can talk to you and get things cleared then and there, so that we are also comfortable. And the most important is that our confidence that what we need to focus on would be to improve the quality of life of the patient and reduce his sufferings. And for that, this can help a lot. So, how to address the total pain in this patient? Once the physical pain comes down, then we can look into the psychosocial aspects of pain. We can explore one by one what are his other concerns related, what are the other factors adding to his pain. And it is very important to educate the family members also what is being given and why this is being given and what all should be monitored and checked. The family should also be aware about that. So I really think that this was a most appropriate case presentation. And one more thing I wanted to highlight here is that there is no ceiling dose. What is the maximum dose of tramadol? Can someone unmute and tell me what is the maximum dose of tramadol in a day in 24 hours?
600 mg per day.
Yeah, it's 400.
No.
So what is the maximum dose of morphine? Yes, thank you, Dr. Shruti. So it has no ceiling effect. That is what I showed you in a chart. It is an agonist drug. If you go on increasing the dose of the drug, the pain relief will also keep on increasing, provided you look in for the monitor the toxic effects. So there is no upper limit for morphine. It is for morphine, fentanyl, methadone, we don't have an upper limit, but titrate the dose depending upon the monitoring the toxic effects as well as depending upon the response to the pain. So these are the only things which we monitor for when we titrate the dose. So I just wanted to highlight that point also. I hope Dr. Athira's patient story, so she has handled it so well, and it would be a learning to many new people who are about to start using opioids in their setting. Is there any more questions from the participants or anybody? Dr. Athira, you want to say something?
Can I ask a question?
Yes, Dr. Sundaram, please go ahead.
Is bisacodyl always effective in relieving constipation? Because I have seen quite a number of patients who are not relieved of constipation despite using bisacodyl.
So, doctor, that would be depending upon the dose of bisacodyl. So in our setting, we usually find it very effective, especially on patients on opioids. So usually we start with 5 milligram 2HS dose. We can go up to 30 milligram a day, 2 we go up to. And if it is not relieving or if the constipation is persisting, then we add on softeners, stool softeners. Ideally would be to start with a stimulant laxative, and then if the constipation is still persisting, we can add on stool softeners.
Okay. Second is, once morphine is initiated, is there no role for NSAID or other analgesics?
So depends upon the type of pain. You might have already gone through the pain session. So if it is a pain having an inflammatory component, opioids have very less role. I mean, morphine has very less role in that. So there, steroids can help. Then NSAIDs can help. And also if there are like specific pains where adjuvants are needed, then I don't know whether a session on adjuvant was already taken.
Yeah, it has been taken.
It was taken?
Yeah.
It was, okay. So those are kind of drugs which are normally not analgesic, but in certain situations they can produce analgesic effect. some muscle relaxants, corticosteroids, all can be used as adjuvant drugs. Tricyclic antidepressants are all used as adjuvant drugs. So, along
No,
with
in this particular case which we have discussed today,
yes, yes,
there is obviously a lot of inflammatory component is there, and already morphine has been initiated and pain has been controlled to some extent. Now, is it essential that we can switch over to NSAID, or just morphine alone along with the antidepressant can be continued?
So I'm not very sure about this. Dr. Adra might be able to explain much, but what I feel in this scenario would be only if it is an acute inflammatory condition, NSAIDs can help. So I see that over-the-counter medications would mostly be NSAIDs that the patient might have taken.
Yeah.
And steroids had also been tried. So mostly the pain seems to be of a neuropathic type with a nociceptive component also. So it would be mostly helpful. Morphine would be the ideal drug, and you'll be learning methadone in next session. It would be the most appropriate in this session, this patient that you'll be learning in your next session. I think it's on methadone, right? Because both nociceptive and neuropathic components are there. So would be more appropriate in such a patient, methadone.
Thank you. Thank you.
Thank you, Dr. Sundaram. Are there any more questions?
Hello.
Yes, Dr. Ashish?
Madam, any antibiotic has any role in this one? Secondly infected.
So I think antibiotic depends upon, I'm not sure about it. Dr. Amirtha, I think she has already, the patient was on a course of amoxiclav and I think metronidazole also. But I'm not sure whether still there is any infection involved.
It's mainly because the chin area, on evaluation, the chin has the submental and submandibular area has a slight redness. Okay. So during the biopsy, there was sinus opening. He explained us, told that there was sinus opening at that time. Okay. So it healed after biopsy and taking a antibiotic course at that time. When presenting to us, he had slight erythema of the submental and submandibular region. So that is why we prescribed a course of antibiotic for 5 days.
I hope that clears Dr. Ashish's question.
Okay.
So Dr. Siddharthani, I think your session is mostly related to, your question is mostly related to the communication. So how to explain about the recurrence to the patient. So this might come up in your communication sessions and you can put this again in that session, I think. Any step to stop morphine post-pain control? Of course, if the patient is having adequate pain relief, we can step down morphine also, but that should be, we should slowly withdraw morphine and step down morphine. If the pain relief is adequate, there is no point in continuing with the morphine. If the patient is having adequate pain relief with the morphine, then that needs to be continued. But if you can step down morphine and have the patient is having adequate pain relief, then that can be, yes, we can go back on the ladder. We can step down to tramadol, depending upon the assessment of the pain that can be done. Yes, Dr. Gauri.
Hello.
Yes, Dr. Ashish, please go ahead.
Saying about the patient is, Dr. Adra is saying patient on morphine, and you are saying about the role of steroids. Is it needed along with the morphine?
Yes, it is an adjuvant drug, Dr. Ashish, and the role of steroids is different from that of morphine. So, in this patient, it could be used for there could be peritumor edema in this patient where steroids could be very useful.
There was lymphedema of the region And as a anti-inflammatory compound, he didn't prescribe any NSAIDs. So instead,
Okay, Dr. Adira, when you are giving this
agent,
steroids, it
the
affects the immunosuppression. And have a antifungal has any role in this one?
actually oral hygiene maintenance is enough, sir. Usually in chemo and many cancer patients, for lymphedema control and all, steroids are usually prescribed in a small amounts. And also pre and post chemo regimen, there will be a small amount of steroid will be there.
Okay, then that's why I'm asking. Antifungal have any role, topical antifungal?
Actually,
Yes.
there were no signs of fungal infection currently. That is why we asked for the salt and baking soda rinse and all. Okay, we didn't prescribe any oral mouthwashes because already he having xerostomia. The mouthwashes will cause again dry the oral cavity, and all these drugs have oral dryness as the dry mouth as the complication. So that is why only asked to have salt and baking soda rinse. It will have a moisturizing effect.
Okay. So you are
Asked to
prescribing
have
any
good oral hygiene. Actually, no, he asked for, he want any wet mouth type of, so he told that no, he will increase the oral intake of water because he already used wet mouth and all, it was not effective.
You're
for
doing
him.
the salivary substitute, isn't it?
Yeah,
Not the
salivary
salivary.
substitute, not salivates.
Okay. Thank you.
Because of radiation, there was radiation complications like fibrosis was there, trismus was there, xerostomia, everything is there as a part of radiation complication.
So yeah, thank you, Dr. Amirtha, for that. But Dr. Ashish, to your question, I would like to add that in our practice, what we usually do is that if there is any sign of fungal infection orally, we do start with a systemic dose of oral fluconazole. Usually it is 150 milligram once daily for 7 to 14 days. And candid mouth paint, it's a clotrimazole mouth paint, is also given. Because there are very, as you said rightly, that the patients are immunosuppressed and there are very high chances of this oral thrush converting into an esophageal candidiasis or lower down infections can occur. So we do treat such patients on oral fluconazole.
Okay, thank you.
Thank you. Hope, I think we are 10 minutes past the session time. If you have any more queries, please send it to your WhatsApp group. Sangeet can send it to me and I can reply back to you.
Thank you, ma'am. Thank you for the wonderful session. Thank you, Dr. Amirtha, for the case presentation and explaining all the doubts of the participants. Thank you all for participating in this session. Thank you. Let's see you in the next session. Bye.
Thank you. Bye.